and I work for the Emergency Care Improvement Support Team. Today I'm going to be in conversation with my colleague Pete Gordon, who was the creator of the Safer Patient Flow bundle. And we're going to have a bit of a conversation about the bundle today. We're not going to talk about the technicalities of it and what's in it. It's more about the ethos behind it, where it originated, and hopefully, Pete, you'll be able to give us some tips on the implementation of the bundle. We will leave some links below around to get you some resources around Safer if you'd like to explore the technicalities of it a bit further. So welcome, Pete. It's good to see you today. Tell us a bit of background about Safer, Pete. Where did it come from? How did it originate?
Well, actually, Tim, the genesis was about 8 or 9 years ago. I was working in an acute trust, and ECIST visited, so the team we both work for now, and they came up with really good advice about how you could reduce unnecessary waiting. And it was particularly around probably medical inpatient wards, really. And I was thinking about, I was working in an improvement team with some great colleagues at the time. And I was thinking there's sort of a bundle of things here that actually, if you do them consistently, will probably reduce variation. Then what came to me was my experience of being a critical care nurse and something called the ventilator care bundle. And care bundles are, creating simple rules, standardized simple rules. And the ventilator care bundle was, you do 4 or 5 things every day for ventilated patients, and if you do them, you reduce ventilator required pneumonia. So that was a sort of genesis, really, where it originated from.
Brilliant. So there's something there around consistency and doing things every day that I'm picking up from you. Just some simple rules, some simple things that you should do, that teams should do every day. Set some kind of baseline standards. That's great. So what do you think made it resonate with people? Because actually, it started very small, but actually most people in the NHS would know of Safer now, wouldn't they? And it's referenced in lots of documents. Why does it resonate with people?
Well, look, I think it resonates with a number of people, not everybody. I think one of the things is when people hear that it's genesis, it's not being created in some office room or something like that. I think that it helps it resonate with people. But I also think the thing that you just mentioned there, Tim, that these are simple rules, they're not complicated. Every patient needs to be reviewed every day. Patients should all have a plan that they know about. So because it feels like the right thing to do, I think that probably helps it resonate. As long as it's explained properly to people and it's not overcomplicated, it tends to resonate when you capture hearts and minds. What are we trying to do? Well, we're trying to reduce unnecessary waiting. We're trying to, save patients' time. We're not trying to create extra burden on frontline staff. So I think there's some of the reasons why it resonates with a lot of people, but maybe not everybody.
So you're clear there. This isn't a bureaucracy. This isn't a tick box. Have we done this? Have we done this? Have we done this? It's more. No. The conversation is really about why, and that you keep coming back to reducing unnecessary waiting there.
Yeah, I think so. I think, look, one of the things is we're full of, what shall we do about a problem? But this is, what's the purpose here? And the purpose, which is going to connect people, their hearts as well as their minds, but is what are we trying to do? And we're trying to help patients. Anyone who's experienced unnecessary waiting, whether that's waiting, I waited outside 3 weeks ago for my uncle for a number of hours because I was waiting for his TTOs. And to me, that was a preventable problem for a man of 92. So as long as we come back to the core purpose, which is, helping people and, the type of things that I would want for my parents, for my loved ones, my friends, that's where I'm coming from in terms of the purpose, the why.
So the why is really important there, and that kicks back to things like the work of Simon Sinek and his seminal piece on starting with why before you move into the how and the how and the what, which is
exactly
what's important in this conversation. And equally there, you talk there about the value of stories, don't you? The patient stories and the way that stories can illustrate a need for change and a need for improvement and help us with that purpose too.
Yeah, no, exactly. And actually, if you use patient stories when you're implementing Safer or something similar, I think patient stories, people feel them, don't they? It could be my mum, it could be your mum. And we've all got stories, haven't we? I often when I'm talking about Safer, I talk about the time my mum was, what time can I pick her up? She could have gone home on the Friday, but come on the Monday. What time? I can come at 10 o'clock. Well, no, actually come at 4 o'clock because then she'll have had her medications done. But I was thinking, well, she can go now. So the story resonates with people, and we all have them, don't we? And some of us who've been through the hospital system or had loved ones through the hospital system know it, and you feel it. You feel it here. I mean, you really feel it. It's not a pleasant experience, unnecessary waiting.
Absolutely, absolutely. So, talk us through some tips then, Pete. If you were working with a trust or a ward team to implement the Safer Patient Flow Bundle, how would you start, and what would you do? What would your top tips be, having worked with this for a long time now?
Yeah, well, the top tip would be, this isn't something which should be mandated. This is guidance. It's not performance management. Thou shalt do this. There's 5 elements to it, which I won't go through. You can see that in the slides if you follow the link below. But first of all is keep it as simple as you can. Making things unnecessarily complex is not right. So you should be able to explain what safer is in about 1 or 2 minutes. But then, for a local team, localize it, make it work for you. So, if, a senior review doesn't need to be a consultant, it should be an ST5 or a nurse consultant. That's fine. Adapt it, the way you communicate with patients, and everyone has a really clear plan in the medical notes, adapt it. So to localize it really. Then also one of my big top tips is, give it a go. For example, can we, if we're a medical ward, can we pull our patients to the ward and choose them ourselves earlier in the day? Give that a go. But also, probably, if I was on a medical ward, one thing that's always struck me is that frontline teams, incredibly busy, but having a knowing how you're doing board, which is something which has some 4 or 5 run charts that people can see at a glance to say, actually, do you know what, at the moment, we only get 15% of our patients off discharge before midday. What can we do about that? The number of long stay patients, the number of discharges per day, but in the right format. But also with that measurement is, don't have onerous dashboards that you expect a ward manager to go and have to hunt down in a computer. It needs to be visual. It needs to be in front of you. And that's one of the biggest complaints from clinical teams. We don't really know how we're doing. Make it easy for us. So there's some of the tips, but localize it, make it work for you, adapt it, and don't worry if you change it. It was created by just someone who's fairly normal, which is myself, as an ex-critical care nurse.
Absolutely. I can certainly vouch for that, Pete. And just one thing finally to pick up on there, you touched on performance management, and obviously whenever we're trying to deliver something new, I would see it as a spectrum between performance management and improvement science. And obviously you probably need a bit of both at some points, but from what you're saying, you would say that Safer definitely sits in the improvement science space in terms of the techniques for implementation.
Yeah, definitely. I mean, I couldn't advocate more strongly that, if you think you're going to performance manage the Safer Patient Flow Bundle, as the creator, I'd say that's exactly the wrong thing to do. If you don't want it to work, mandate it. Big suggestion, follow a quality improvement approach, give it a go, adapt it, but don't performance manage it. I mean, beating people up because of X, Y, and Z, well, it doesn't work. It doesn't work with this. So I'm really big on this one. Don't performance manage it. Use pragmatic improvement approaches, which are known to work. If you engage the people, the answers are there on the front line. We've all worked. I mean, Tim, you're a nurse like me. I mean, you've worked on wards where when you're empowered, you just do stuff. You feel energetic. But when it's all top down and you think, well, no one's really listening to me, I'm just told what to do all the time, you don't really flourish. You don't get the energy and the drive. So that's a long answer to your question, Tim, but no, it shouldn't be performance managed.
Pete, that's brilliant. And I think there's an awful lot for us to take away from there. And it makes the way you speak there makes the Safer Patient Flow Bundle and its implementation exciting, doesn't it? And there's a real opportunity for clinicians, as you say, getting people in the heart and getting people's purpose,
Yeah.
really using this as an opportunity to really empower staff to do something really practical and to support things. I think I really like there the start small, just try it maybe on one ward, just try one element of it, see how you're getting on, use some of the techniques around measurement for improvement and improvement science to really support the journey. Thanks so much for your time. We could talk for a lot longer about the Safer Patient Flow Bundle, and I'm sure we'll pick this up again in future bite-sized podcasts. But that's some great tips, and Thanks so much, Pete.
Brilliant. Thanks, Tim.